Hello.
Right, should we start?
Yeah.
Thank you. Good afternoon, everybody. Welcome to this afternoon episode of Pursue. This is Pursue 5X, where we'll be dealing with the pathology of blood vessels and heart, and we are streaming live from Kolkata. And the topic is very interesting, which is the blood vessels, structure and function. And after that, we will be talking about hypertensive heart disease and aneurysm. And to talk on that, we have Dr. Colonel Tanushri Mukherjee. Dr. Mukherjee has been a graduate from GMC Bhopal. She did a post-graduation from AFMC Pune, then her DNB in pathology. She's trained in Tata Memorial Hospital, Mumbai for 2 years. She's a Diplomate Fellowship in the Royal College, London, Professor and Senior Advisor, Pathology and Oncopathology at the famous Command Hospital, Eastern Command. She is a recognized teacher for West Bengal University of Health Sciences, a DNB teacher, an affiliate member of the RC London, life member of ISC and IAPM with more than 30 publications in national and international journals, Best Reviewer Award. She is also the HOD Command Hospital, was an ex-HOD of Command Hospital Chandi Mandir, and presently she is a professor and senior advisor in the pathology and oncopathology at Command Hospital, Eastern Command. Before I ask ma'am to start, let me request everybody to keep the mic muted, the camera off, and please don't share your screen. With this, let me request ma'am, please share your screen and let us start.
Thank you so much.
Yeah, I can see your screen. Just make it full screen, please.
I'll make a slideshow.
Yeah.
Yes.
Perfectly fine. Yeah. Please start.
Okay. Thank you. So the topic is blood vessels, and the structure and the function of blood vessel is very vital and important because the link is with all the diseases which occur, like the hypertensive heart diseases, aneurysm, arteriosclerosis, atherosclerosis. So first, for the postgraduates, it is very important to be clear with the structure and the function of the blood vessels and the basic mechanism that how the pressure is regulated. So blood vessels are fundamentally the tubes composed of smooth muscle cells and extracellular matrix with luminal phase covered by endothelial cells. So basically what we see here, we are having these three layers: tunica adventitia, tunica media, and tunica interna, with a lumen or a opening. Then the structure-function relationship changes throughout as we move through the cardiovascular tree. The tunica thickness and composition is variable, and there is regional vascular specialization. Although they have the same general constituents, the various layer thickness differ as a function of hemodynamic forces and tissue requirements. So, as we see, the arteries, the elastic arteries, which are the conducting arteries basically, and they are near to the heart, like the aorta, arch vessels, iliac, pulmonary artery, thick walls, more elastic fiber, less smooth muscle, and they lose elasticity with aging. These are the diameters and the comparative diameter of the elastic artery with the muscular artery. So we see here the elastic artery, the thickness is, the diameter is more. So the aorta and the elastic artery, they can vasoconstrict or vasodilate. The large arteries expand, absorb the pressure wave, then release it with elastic recoil, which is called as the wind tussle effect. And this, as we see, how it is important in regulation of the pulse pressure and the blood pressure, and helps to push the blood along during diastole. With aging, less expansion and recoil is there. The muscular arteries are the distributing arteries, like the coronaries and the renal, deliver blood to organs, more smooth muscle and less elastic fiber. Again, the comparative diameter we see, the muscular artery only diameter is 6 millimeters, elastic artery 1.5 centimeters. Then the arterioles. Arterioles function distribution of blood in the organs. Composition varies depending upon the position. More muscle, less elasticity nearer the heart. Regulate flow from arteries to capillaries, and flow, it depends upon the pressure divided by the resistance, and very resistant by changing vessel size. This is the site of blood pressure regulation. Then the microcirculation connects the arteries and veins. Capillaries, which are found in nearly every tissue in the body. Higher the metabolic rate, more capillaries in the tissue. Allow exchange of nutrients and waste between blood and tissue. Capillary structure is simple, with a basal lamina and endothelial cell lining. The types of capillaries, they are of three types. The continuous capillaries, continuous endothelial cells except for clefts between the cells, and the most capillaries in bodies are of this type. Then the fenestrated capillaries, fenestrations allow for filtration of small substances. The glomerular capillaries in the kidney, and third is the sinusoid capillaries, which are found in liver. There is wider gaps between endothelial cells, allowing the RBCs to exit the capillary. So, the vessel function, capillary function is site of exchange between blood and tissues, delivery of nutrients and removal of waste. Slow flow allows time for exchange. Then the nutrient exchange. Then the venules, which collect blood from capillaries and carry it to veins, become more vessel-like walls as moved from capillaries. Veins, the interna, it is thicker than the arteries. Media is thinner, there is less muscle. Externa is thick, there are walls, and there is low pressure. So high compliance is there because it changes volume easily with small change in the pressure. So now we can compare to what is the difference, because veins, they require more distensibility and high compliance. So this is the histological section, the difference in the morphology and the light microscopy. The tunica media thickness differentiates artery from the vein. This is again the photomicrograph showing the difference in the structure of artery and vein. So as we see here, at rest, 60% of blood is located in veins and venules, and they serve as reservoirs for blood, storing it until needed, particularly veins of abdominal organs and skin. And this regulation is through various mechanisms like the autonomic nervous system. It regulates the volume distribution with vasoconstriction and vasodilatation. So various factors which affect the flow of blood, like the viscosity of blood, because with various diseases, the blood viscosity, if it increases, the resistance increases, and the resistance is proportional to the vessel length and the vessel diameter, and so all this factor contributes to generation of a resistance which can cause hypertension. So these mechanisms need to be understood. So the regulation of pressure and resistance, like the systemic vascular resistance, the total peripheral resistance, and the total resistance, this all vascular resistance is offered by the systemic vessels. So basically you should know the peripheral vascular resistance and the systemic vascular resistance and how to calculate there. Not too much calculation is required, but basically once you are asked like how do you, what is the cardiac output measured or the stroke volume, so few terms which has to be known. Because in the regulation of blood pressure chart, these all things will come later. So it is basically good to have a basic knowledge of this. So resistance is highest in the arterioles, and there is relationship of radius to resistance due to smooth muscle. And what is like the pulmonary arterial pressure, then pulmonary capillary bed pressure, cardiac output, mean arterial pressure, central venous pressure. So this all terms are important. So basically the systemic blood pressure and arterial blood pressure, as you know, systolic, diastolic pressure and the pulse pressure. So as I discussed the Wind-Kessel effect, so Wind-Kessel effect decreases the pulse pressure, which is the difference between the systolic and the diastolic pressure. And the hardening of the arteries, what they do, they increases the pulse pressure. So this pressure regulation is important when we discuss the hypertension pathogenesis. Then the capillary blood pressure, it's a relatively low blood pressure. Capillaries are fragile and high pressure tears them up, and capillaries are very permeable. Then two mechanisms which help for venous return are the skeletal muscle pump and the respiratory pump. Then velocity of blood flow, it is inversely proportional to the cross-sectional area of the vessels, like aorta. As you see here, the cross-sectional area is 3 to 5 centimeters square and velocity is 40 centimeters per second. And capillaries have a much larger cross-sectional area and the velocity is less. Vena cava again, you see there is only 14 centimeters square and velocity is 5 to 20 centimeters per second. And the fluid movement across the capillaries, they are driven by the following pressures. The hydrostatic pressure is the basic physiology as we know of the vessels. The hydrostatic pressure in interstitial fluid, the hydrostatic pressure in the capillaries, the osmotic pressures, and the osmotic pressure of the interstitial fluid, and the net filtration pressure is the sum of the all. This is the Starling's laws of the capillary. So this is the fluid exchange. On average, 85% of fluid is filtered at the arteriole and is reabsorbed at the venular end. So now I come to the regulation of the blood pressure. Very simple flow chart. As you see here, what all factors, they increase the mean arterial blood pressure. As you see here, the cardiac output is equal to mean arterial pressure. divided by the resistance. So increased cardiac output and increased systemic vascular resistance, they increase the mean arterial blood pressure. And what all contributes to increased cardiac output? The increased heart rate, increased stroke volume. And increased blood viscosity, increased total vessel length, decreased blood vessel radius with vasoconstriction, they all increase systemic vascular resistance. And as I told earlier, the respiratory pump and the increased contraction of leg muscles, increased blood volume, they all increase the venous return. So these all are interconnected, and this flow chart very nicely explains in the exam if you make this and pathogenesis and blood pressure, this is very nice. Then the various mechanisms are there. There are short-term mechanisms which are CNS controlled. There are cardiac centers in the medulla, the vasomotor centers, send sympathetic output to blood vessels, vasoconstricts or vasodilates as needed. And they receive input from baroreceptors or the chemoreceptors. Then the CNS reflexes, which are baroreceptor initiated reflex located at carotid sinus and aortic arch, they monitor changes in the blood pressure. As I have told, the autonomic nervous system, the sympathetic nervous system, they regulate activity and the vascular tone. Then the chemoreceptor initiated reflexes, like in carotid bodies, aortic bodies, they monitor changes in the chemicals and increases the stresses, result in increased sympathetic activity and increased blood pressure. Then the influence of higher brain centers, not involved in minute-to-minute regulation, but it influences the vasomotor center depending upon the conditions like temperature regulation or in stress. Then the hormonal regulation. The various hormonal systems like renin, angiotensin, aldosterone. Renin is an enzyme from kidney, results in formation of angiotensin 2. Angiotensin 2 is a vasoconstriction, stimulates antidiuretic hormone, stimulates aldosterone and sodium reabsorption, which in turn increases the blood pressure. Then adrenal medulla, epinephrine, norepinephrine, increases the cardiac output, increases heart rate, increases stroke volume, constricts abdominal cutaneous arterioles, dilates cardiac and skeletal muscle bed, and increases blood pressure. And the antidiuretic hormone, osmoreceptors in the hypothalamus, retain fluid, vasoconstriction at high levels. So these are the stresses to increase the blood pressure. And the atrial natriuretic peptide is one of the regulators. This is a vasodilator. There is increased sodium and water loss, so it opposes the aldosterone. It is released from atrial cells in response to increased blood pressure. And the long-term regulation is by renal mechanism. There is kidneys, increased blood pressure, increased urine flow to decrease the blood pressure. And there is decreased blood pressure, there is a decreased urine flow to increase the blood pressure. So this is the complete regulation. There is a vasoconstriction, there is increased blood volume, there is increased water resorption by the kidneys, and which leads to the increased arterial pressure. So this flow chart is again very important in seeing all the baroreceptor induced and the hormonal influence on the control of blood pressure. So this is the blood pressure regulation, again by a simple flow chart: cardiac output, peripheral resistance, the local factors, and then the cardiac factors like heart rate, contractility, then the neural factors, what are the constrictors, the alpha adrenergic, dilators like beta adrenergic, then the humoral factors, the vasoconstrictors are like the endothelin, leukotrienes, thromboxane, catecholamines, angiotensin 2, and dilators are prostaglandins, kinines, nitric oxide. And blood volume regulators, atrial natriuretic peptide, mineralocorticoids, and sodium. So, control of blood flow, there is auto-regulation, local automatic adjustment of blood flow to match the tissue needs. Like warming increases vasodilatation, cooling there is increased vasoconstriction, chemical changes, then myogenic control, Then special areas like skeletal muscle, there is wide variability. As per the oxygen requirement, there is low oxygen, increased vasodilation to increase the flow. Then brain, there is very little variability in flow. Stores few nutrients, so flow must be maintained, and there is a metabolic regulation. So, vascular structures and function, to summarize, you say that all vessels are lined by endothelium. Although all endothelial cells share certain homeostatic properties, endothelial cells and specific vascular beds have special features that allow for tissue-specific functions. The relative smooth muscle cell and extracellular matrix content of vessel walls varies according to the hemodynamic demands and functional requirements. Endothelial cell function is tightly regulated in both the basal and activated states. Various physiological and pathophysiological stimuli induce endothelial activation and dysfunction that alter the endothelial cell phenotype, like procoagulative versus anticoagulative, pro-inflammatory versus anti-inflammatory, non-adhesive versus adhesive. So now I will discuss about the disease entity, which is hypertension. It is a common disorder affecting 25% of the population. It's a major risk factor for atherosclerosis, congestive heart failure, and renal failure. It may be primary or less commonly secondary. In 95% of cases, it is idiopathic or essential. The remaining cases, secondary hypertension, are due to primary renal disease, renal artery narrowing, or adrenal disorders. Essential hypertension, or the idiopathic primary type, represents 95% of cases and is a complex multifactorial disorder involving both environmental influences and genetic polymorphisms that may influence sodium desorption, aldosterone pathways, the adrenergic nervous system, and the renin-angiotensin system. Hypertension occasionally is caused by single gene disorders or is secondary to disease of the renal arteries, kidneys, adrenal glands, or other endocrine organs. So this is like the two entities, hyaline arteriosclerosis and the hyperplastic, like onion skin arteriosclerosis. Arteriosclerosis, as I will discuss, is the thickening of the arteries. So these are the two types, which is a very important cause of hypertension and the morphology of the hypertensive vascular disease. So there is an interplay of renin, angiotensin, aldosterone, and atrial natriuretic peptide in blood pressure regulation that I discussed previously. So this flow chart, this very nicely explains all those considerations, that how the sensors, cardiac volume sensors are there is regulation of the blood pressure, and how the balance is shifted from normotension to a hypertension. So these are the various causes, like essential or primary idiopathic, 90 to 95% of cases, secondary renal causes like acute glomerulonephritis, chronic renal disease, polycystic disease, renal artery stenosis, renal vasculitis, and renin-producing tumors. Then the endocrine factors like adrenocortical hyperfunction, exogenous hormones, pheochromocytoma, acromegaly, hypothyroidism, hyperthyroidism, pregnancy-induced, and cardiovascular, coarctation of the aorta, polyarteritis nodosa, increased intravascular volume, increased cardiac output, rigidity of the aorta. And the neurological factors like stress, sleep apnea, increased intracranial pressure, and psychogenic cause. Mechanism, as I have told already, it is reduced renal sodium excretion, increased vascular resistance due to vasoconstriction or structural changes in the blood vessels, genetic factors, and environmental factors. So blood pressure, it is determined by the vascular resistance and cardiac output. Vascular resistance is regulated at the level of the arterioles, influenced by neural and hormonal inputs. Cardiac output is determined by heart rate and stroke volume. Stroke volume is influenced by blood volume. Blood volume is regulated by renal sodium excretion or desorption. And renin, a major regulator of blood pressure, is secreted by the kidneys in response to decreased blood pressure in efferent arterioles. Renin cleaves angiotensinogen to angiotensin. Subsequent peripheral T2, which regulates blood pressure by increasing vascular smooth muscle cell tone and by increasing adrenal aldosterone secretion, which consequently increases renal sodium resorption. So now I will be coming to atherosclerosis. Before that, I must discuss the arteriosclerosis, which is a hardening of the arterioles, the arterial wall thickening and loss of elasticity. 4 causes are recognized. It affects small arteries and arterioles and causes downstream ischemic injury. 2 variants, as I've said earlier, the hyaline and the hyperplastic arteriolosclerosis. The Monckeberg medial sclerosis is characterized by presence of calcific deposits in the muscular arteries, usually centered on the internal elastic lamina. In individuals older than 50 years of age, the lesions do not encroach on the vessel lumen and usually are not clinically significant. The fibromuscular intimal hyperplasia is a non-atherosclerotic process that occurs in muscular arteries larger than the arteries. So with this background, when we discuss atherosclerosis, it is an intima-based lesion composed of a fibrous cap and an atheromatous gruel-like core. The constituents of the plaque include smooth muscle cells, extracellular matrix, inflammatory cells, lipids, and necrotic debris. Atherogenesis is driven by an interplay of vessel wall injury and inflammation. The multiple risk factors all cause endothelial cell dysfunction and influence smooth muscle cell recruitment and stimulation. Major factors are there that I will discuss later also, the modifiable risk factors and the non-modifiable. The major modifiable factors are hypercholesterolemia, hypertension, cigarette smoking, diabetes mellitus. Atherosclerotic plaques develop and grow slowly from a fibrous like fatty streak and with the fatal complications like plaque rupture, thrombosis, and embolization. Stable plaques tend to have a dense fibrous cap, minimal lipid accumulation, and little inflammation, whereas vulnerable unstable plaques have thin caps, large lipid cores, and relatively dense inflammatory infiltrate. So here you see intimal lesion and how it progresses. The type 1 is the initial lesion. Type 2, fatty streak, mainly intracellular lipid accumulation. Then there is a extracellular lipid pools, intermediate lesion. Then there is the atheroma. Type 4 is type 2 change with core of extracellular lipids. Then type 5 is a fibroatheroma. And type 6 is a complicated lesion with surface defects, hematoma, hemorrhage, and thrombus formation. So the factors, major factors, non-modifiable, age, gender, family history, genetics, and controllable like hyperlipidemia, hypertension, smoking, diabetes mellitus. Lesser factors, uncertain factors could be obesity, physical inactivity, stress, estrogen deficiency, high carbohydrate diet, and controllable factors could be alcohol, lipoproteins, chlamydia. So this is the atherosclerosis. The most popular hypothesis is the response to injury hypothesis. It's a chronic inflammatory response of the arterial wall to endothelial injury. So there is a endothelial cell injury resultant endothelial dysfunction leading to increased permeability, leukocyte adhesion, and thrombosis. Accumulation of lipoproteins, mainly oxidized low-density lipoproteins and cholesterol crystals in the vessel wall. There is a platelet adhesion. There is monocyte adhesion to the endothelium, migration into the intima, and differentiation into macrophages and foam cells. Lipid accumulation within macrophages, which respond by releasing the inflammatory cytokines. Smooth muscle cell recruitment due to factors released from activated platelets, macrophages, and vascular wall cells. Smooth muscle cell proliferation and extracellular matrix production. So this is the sequence of events which occurs in the pathogenesis of a formation of a atherosclerosis plaque. So, to summarize that, endothelial injury, then the role of inflammation, surface selective adhesion molecules like the VCAM1, role of cytokines, role of T cells, then immune activation, then bacterial or viral factors could be there, then role of lipids and role of smooth muscle cells. So this is some of the simplified view that how these interleukins are implicated in the formation and aggravation of atherothrombosis. So the treatment could be based upon the individual molecule based. So the therapeutic like the inflammasome inhibitors which are used like anti-IL-18, anti-IL-1 alpha. These are the recent advances which I have taken from the 2019 American Heart Association article. This is the morphology, the intimal thickening and lipid accumulation, gruel-like consistency, distribution, abdominal aorta, coronaries, popliteal, and advanced lesions cause rupture, ulceration, hemorrhage, thrombosis, aneurysm. So earlier lesion was the fatty streaks and then the atherosclerotic plaque, and which then depends upon the complications. They become a vulnerable plaque. And another disease which is very catastrophic is the dissection. What is a dissection? The blood separates the laminar planes of the media to form a blood-filled channel within the aortic wall. 40 to 60 years common. At a younger age, if the patient is of Marfan syndrome, the most common cause of dissection is hypertension. The types, depending upon the level of the aorta affected, involves ascending aorta or both. Type A. Type B does not involve the ascending aorta, but lesion becomes distal to the subclavian artery. So the classification is a DBK classification, type 1, type 2, type 3, and the Stanford, which is type A, then type B. The most frequent pre-existing histologically detected lesion is cystic median degeneration of the aorta. There is a true lumen as well as a false lumen, as you can see in the photomicrograph. So you see here, the aneurysm could be of a saccular type or a fusiform, because when we do grossing and post-mortem and autopsies and we see, you have to be very, very carefully seeing these things. Like the saccular aneurysm, you can see here quite nicely than the fusiform. And sometimes there may be false aneurysm, like the blood is collected in the extravascular connective tissue. And then there is a dissection when there is tear in the intima. Blood has entered the wall of the vessel and separated the layers in an aortic dissection. So, this is again classification DBK type. DBK proximal involves the ascending aorta, type A, either as part of a more extensive dissection, DBK type 1, or in isolation, DBK type 2. Then type B dissections are distal or DBK type 3, which arise after the takeoff of the great vessels. Type A dissections typically have the most serious complications and greatest mortality. So in most dissections, the intimal tear marking the point of origin is found in the ascending aorta within 10 centimeters of the aortic wall. Such tears usually are transverse or oblique in orientation and 1 to 5 centimeter long with sharp, jagged edges. The dissection plane can extend retrograde towards the heart or distally, occasionally as far as the iliac and femoral arteries, and usually lies between the middle and outer thirds of the medium. External rupture causes massive hemorrhage or results in cardiac tamponade if it occurs in the pericardial sac. In most instances, no specific underlying causal defect is identified in the aortic wall. As I said earlier, the most frequent histologic detectable lesion is a cystic medial degeneration, which is characterized by smooth muscle cell dropout and necrosis, elastic tissue fragmentation, and accumulation of amorphous proteoglycan-rich extracellular matrix. So, abdominal aortic aneurysms typically occur between the renal arteries and the aortic bifurcation. They can be secular or fusiform and up to 15 cm in diameter. Extensive atherosclerosis is usually present with thinning and focal destruction of the underlying medium. The aneurysm sac contains bland, laminated, poorly organized mural thrombus, which can fill much of the dilated segment. Then the aortic aneurysm, other forms are the inflammatory aneurysm. There is a dense periaortic fibrosis containing abundant lymphoplasmacytic inflammation, macrophages, giant cells. And then there is something which is very recent and new, like the immunoglobulin G4, IgG4 related diseases. There is a marked tissue fibrosis with frequent infiltrating IgG4 expressing plasma cells. Because these IgG4 related diseases can affect a variety of tissues, almost all the systems, and affected individuals have aortitis and periaortitis that weakens the wall sufficiently in some cases to give rise to aneurysm. So recognition of this entity is very important because steroid therapy is the treatment for this. And then there are the mycotic aneurysms and circulating microorganisms, as in bacteremia for infective endocarditis, feed the aneurysm wall or the associated thrombus. The resulting suppuration accelerates the medial destruction and may lead to rapid dilatation and rupture. So, this is about the aneurysm, and so I have correlated the structure and the function with the regulation of the blood pressure and with the aneurysm. So, as you know that these are all interconnected and very important that we know the physiology to correlate with the disease process. Thank you. Any questions?
Yeah, hello ma'am.
Yeah.
Great. Very detailed.
Any questions? Yeah.
No, there are no questions
Yeah.
on the YouTube. Neither there is in Google Meet. Very detailed description, hypertension and atherosclerosis and aneurysm. I think that will be very useful for everybody. When will we have the next class?
On 21st, there is a Ram Navami. So because in my hospital, not only in the signal is very less actually. So it will be not
fair enough.
possible.
So we'll keep it for 21st. The vasculitis.
Vasculitis, yes.
Right.
I'll take the vasculitis. Yeah. Thank you. Thank you so much.
Thank you much. Thank you so much, ma'am. Take care.